In developing a prognostic, there's really two things you want to know. You want to know where someone is today in terms of their progression towards a disease, and you want to know how quickly they're moving towards that end. So those really fall into assessments of status and trajectory. We already measure status quite well in the clinic. We have fasting plasma glucose, and we have HbA1c. These are the markers that really tell us someone's status relative to an existing diabetes scale. But a fasting plasma glucose or an HbA1c number is just a status check. It tells us where a patient is relative to a normal result in the diagnostic cutoff for diabetes. It's known that patients with the same glucose levels don't necessarily have the same risk for developing diabetes. So the problem is when a clinician has two patients with the same glucose status. How do you differentiate between them? Is someone at risk because they'll be unable to maintain their glucose homeostasis over the long term? Or do they have an underlying physiology that will protect them and keep them stable over the long term? Gaining a more accurate assessment of diabetes risk, a more complete picture of the puzzle, is really a process of understanding the underlying pathophysiology of diabetes development. Which biological pathways and which biomarkers associated with those pathways will tell you the most about the underlying physiology that supports glucose homeostasis over the long term. The research in developing PreDx DRS identified three primary pathways: glucose metabolism, inflammation, and adipose function as being the most strongly implicated in the progression to disease. So in addition to fasting plasma glucose and HbA1c, the test includes biomarkers like insulin, because we know that the amount of insulin that's circulating is a reflection of how hard the pancreas is working to keep up with the demands of disposing glucose. We also measure markers from the inflammatory pathways: C-reactive protein, interleukin-2 receptor alpha, and ferritin. Inflammation strongly degrades one's ability to maintain glucose homeostasis over the long term. And we measure adiponectin, which is reflective of how healthy someone's fat cells are and how well their fat can accommodate excess calories over the long term to help prevent diabetes. The weighted contribution of the 7 PreDx DRS markers allows clinicians to not only identify those individuals at highest risk, but also provides them with biomarker-specific information that can lead to a better understanding of why their patients are at risk. Access to this type of data can have a significant impact in the clinical setting. Let's say we have 3 patients with the same fasting glucose level, and each one of them is given a PreDx DRS. Their PreDx Diabetes Risk Scores reveal that one has a lower risk for converting to diabetes within 5 years, yet another is at a moderate risk, and a third is in the high-risk category. What those scores are telling us is that these 3 patients have different underlying physiologies, and that the biomarkers measured in the PreDx DRS test are revealing a difference in the capacity of these people to withstand the kinds of insults that lead to diabetes. The lower risk patient may have quite a lot of healthy fat and a lot of capacity to buffer excess calories, and low levels of inflammation and low levels of insulin secretion, which indicate a lot of capacity left to deal with the changes in insulin resistance. Whereas the high-risk patient may have high levels of insulin secretion already, have dysfunctional fat, high levels of inflammation, and really be susceptible to any insults that lead to a progression to diabetes. PreDx DRS assesses a deeper level of information, capturing and weighing data from 7 predictive biomarkers to produce an integrated score that stratifies a patient's risk of developing diabetes on a scale from 1 to 10, where 1 indicates a low likelihood of converting to diabetes within 5 years, and 10 indicates a very high likelihood of conversion. With PreDx DRS, clinicians can more accurately assess risk, stratify their patients into lower, moderate, and high-risk categories, and manage those patients accordingly. It's really being able to tell the difference between people today and not waiting until they get to diabetes or they stay stable for the next 5 years, which is the premise of the PreDx DRS test.